So I'm Stacey Rosenzewig. I'm a master's student at the University of Michigan, and this summer I was in Dar es Salaam, Tanzania with 3 other students. And the preliminary title for my project is Predictors of Survival Based on Follow-up, Compliance, Treatment Completion, and Demographic and Epidemiologic Risk Factors of Burkitt's Lymphoma Clinical Trials in Tanzania. So just a background on Burkitt's lymphoma. Burkitt's lymphoma is a non-Hodgkin's lymphoma, and there are 3 types: African, sporadic, and AIDS-related. And I'm going to be focusing on the African, or the endemic Burkitt's lymphoma, which is most prevalent in Africa. Presentation is mostly in the jaw and the abdomen, and we have a picture here of a child in Tanzania with a really big jaw tumor before treatment. Burkitt's accounts for about 30 to 50% of childhood cancers in equatorial Africa, and Epstein-Barr virus is detected in almost 100% of these cancers. So this is just a graph showing the distribution of cancer types worldwide, and just to show that lymphomas make up about 20% of the cancers in Africa, but if you would parse that down to equatorial and East Africa, the prevalence, or the incidence, would be a lot higher. So Burkitt's lymphoma was first kind of discovered or characterized in the 1960s by Dennis Burkitt and his colleagues, and they kind of found this Burkitt's lymphoma belt in black here. So about 10 to 15 degrees above and below the equator was where they found the highest incidence of Burkitt's lymphoma. They also found that there was a temperature barrier that influences the occurrence of Burkitt's, and that having malaria predisposes you to get Burkitt's lymphoma. So really early on, it was shown that Burkitt's responds really fast to chemotherapy, and between the 1960s and the 2000s in Africa, random chemotherapy was given to these patients, and there was no standardized treatment, and there was only about a 10 to 20% survival rate. So in the West, Burkitt's has about a 90 to 100% cure rate because they have standard of care chemotherapy that they give. And it's also a different type of Burkitt's, but in Africa they were still seeing a 10 to 20% survival rate. So in the early 2000s, a group of doctors with the INCTR came together and decided that they wanted to try and create a standard of care chemotherapy for Burkitt's. So they started the study called the INCTR 0306 study. There were sites in Nigeria, Kenya, Tanzania, and Uganda. So this trial occurred between 2004 and 2009 in sites in these countries that I just mentioned, and the results were pretty amazing at that time. So they found that there was about a 60% overall survival rate, and comparing that to the 10 to 20% survival rate previously, that was really amazing. And so the treatment that they had was a 3-drug treatment for previously untreated patients with Burkitt's. And the doctors that I spoke to in Tanzania really emphasized that they were trying to do this based on feasibility of resources and drugs available, because you really can't treat patients the same way in the West as you do in developing countries. So this trial had about 350 patients between the 4 countries. Most were between 2 and 15 years old, and there were twice as many boys and girls. And sites of disease presentation that they saw most often were in the jaw, the abdomen, the eye, and the peripheral lymph nodes. So my study was kind of using this clinical trial data and doing the first epidemiologic study on these data. So this study yielded 1 paper, and it was with patients from all these countries. And so there hadn't been, 1, an epidemiologic study, and 2, nothing on Tanzania specifically. So how I started was trying to get access to the Tanzanian clinical trial database, which proved to be the longest and tedious part of the project, which I didn't expect. There were a lot of IT issues because the trial coordinator who was in Tanzania had a lot of databases, but none of them were the final complete database that the IMCTR had. And so I kind of had to work with her and figure out which was the most complete and up-to-date database. And then when I figured that out, trying to get it from her computer to mine was another issue. So I sat down with a lot of IT people, explained many times what I needed, literally just to transfer it to my computer, but that a lot of it was lost in translation. So after that, concurrently kind of, I identified patients who were alive when treatment ended, because I was, my larger goal that I have not finished yet is to kind of look at survival and follow-up of these patients to see how long they have survived on this treatment, what type of follow-up the hospital was implementing to see if these patients are still alive. So something that I didn't mention yet was that the trial was done at Ocean Road Cancer Institute in Dar es Salaam. But just about the end of the trial, all of the pediatric oncology patients were switched to the Muhimbili National Hospital, also in Dar, because more specialists were there, and they don't have any other pediatrics at ORCI. So I had to find patients in the Muhimbili Pediatric Oncology Records Room, but I only had, I think, 10 Muhimbili medical record numbers. The rest of the medical record numbers I had were ORCI specific, and there was no key made for transition of medical record numbers, and they're different at each hospital. So I literally went through the entire, every single medical record in Muhimbili National Hospital Pediatric Oncology Ward to find these medical record numbers. And then the ones I didn't find, I looked through the logbooks, and the logbooks have name of patient, medical record number, and what they came in for. So if they came in for Burkitt's, I would check their name against the database that I had, and then find the medical record number if they were in the study, and then look again in the medical record files to see if I could find them. And these are some of the paper records that I had. And so this picture on the left here are the files at Muhimbili. So even if I had a number that I was looking for, it's hand filed, obviously, so I would probably look 30 to 50 records on either side of the potential number to try and find it. And so I did that, and then I looked through every one of these twice, just kind of going row by row to see if I missed any, because also in the study, one of the providers said that she wrote the study number on the folder, so I was looking for her little number and circled number for that. So had a few ways to find these files. This middle picture is the files at Ocean Road. So these were the files that the kids had during the trial. I actually found all of their files here, but that even if they were here, that didn't mean they weren't here at Muhimbili. So there was some information here, some information at Muhimbili. There was also a follow-up binder that I looked through that had different information than some of the medical records, so I was kind of triple cross-checking everything. And this is a picture of the logbook. Richard had another picture. We used these a lot, and they were sometimes helpful, sometimes not, but I think it was a good indication of who came in for treatment in these locations. So I have a lot of data to go through and kind of definitions to establish, but for initial results of demographic data from the Tanzanian site, the majority of kids were age 5 through 9, and most kids were under the age of 15, and I had about twice as many boys than girls. And for initial survival result after recruitment, so this is both kids who were alive and dead at the end of treatment, but there's, like I said, there's some definitions that I need to identify, but I have about a 12.5% survival after 4 years of recruitment, which is pretty good. And like I said, there's been no epidemiologic study done with this data, so I'm really excited to look into this and dig deeper into the demographic and epidemiologic information with the survival and follow-up. So proposed future analysis, for me, do the first epidemiologic analysis of this, look at predictors of survival, evaluate how patients adhere to the follow-up regimen. Based on the protocol, they were supposed to come in at the beginning every month, then every 3 months, then every 6 months, then every year, and see how well they did that. During the study, there was some money for people to go out and do home visits for them to see if they were still alive, and I think there was still a small separate grant for that. So in some of the medical records, it was indicated, if they were seen at the hospital, or it was a phone call, or it was a home visit. So I want to dig deeper into that and evaluate the method used for follow-up and see if that correlates to length of follow-up and survival. And I think, kind of bigger picture, these results can be translated and help to allocate resources for treatment and follow-up, and can be really helpful for the Ministry of Health and potentially different pharmaceutical companies if they want to come in and if they have other treatment for Burkitt's lymphoma that can potentially increase survival, and also obviously help design interventions to increase survival for these kids. What I learned a lot. So pole pole is a phrase in Tanzania that everyone says a lot, which kind of just means flow, everything just go with the flow. So I think all of us learned that, learned how hard to push, learned how many times to ask questions, because you weren't really sure if the people understood what you were trying to get at. So patience is key. There were a lot of language and cultural barriers. I think people were pretty resistant to the fact that we didn't know Swahili, so I think that was kind of a first barrier that we encountered in people. I think some people were hesitant to help us due to that factor. And going to the last point, that kind of translates into training for research methods. Not a lot of providers or people who work at the hospitals are trained or understand research methods, so even the doctors that I was working with didn't understand why I was looking for this survival data. They didn't understand why, if the kids were gone from ORCI back to Muhimbili, they didn't know why I would need to, follow up these kids or see how long they were surviving. And then definitely learned firsthand that treatment from countries are definitely not potentially transferable to others, because there are few specialists in Tanzania. They have electricity problems. They can't refrigerate drugs all the time. So interventions really need to be designed specifically for that country that you're in. Ideas for future students, I would say they could look at treatment of Burkitt's at Muhimbili now and see what that survival is like, and potentially compare it to the clinical trial data to see if there is a gap, and see where further resources need to go. I think that the population for the clinical trial was pretty comparable to the general population of pediatrics of kids with Burkitt's, because they took anyone who had Burkitt's into this trial. They had separate arms for kids with prior treatment and without prior treatment. So I think generally, or at least compared to other populations in clinical trials, I think it is pretty comparable to general population. And with this data, it can obviously help design better interventions with comprehensive follow-up. Strengths of this research site. So the PI that I worked with was the PI of this site in Tanzania for the clinical trial, and he has a lot of international research experience, international experience and research experience, which I think was key and he asked a lot of really good questions and helped me, word things and design the study really well, and it gave me a lot to think about. Something that I also found that was really interesting was the longevity of the providers there. So I worked a lot with Dr. Jane, and she had been treating patients from 2004 when the trial started, and is still treating patients with Burkitt's today. And she is an amazing woman, and remembers, if I would ask her a name of a patient, she remembers them, she knows where they live, she knows when she last saw them, how they're doing, what type of, where their tumor was located. So I think that is pretty amazing, and I haven't seen that here in the U.S. And then, at ORCI and Muhimbili, there are specialists present, although there are so few specialists in Tanzania, but, if you're going to see a specialist, this is the place to see one. So, higher likelihood of seeing the specialist here. Limitations, like Rose said, Dar is really far from most Tanzanians. It's on the coast, and Tanzania is a really big country. So definitely hard for people to get to these places. Also, even within Dar, it could be like a 3-hour bus ride. So that is a big limitation. As you saw, these are paper records, so things are incomplete, pages are ripped, there's water damage, all these things. And there are no matching between the record numbers. And so I worked in clinical trials before I started my master's, and there is a lot of regulations about how clinical trial documents are kept, and who has access to them and how they're locked and everything. And that was definitely, they did not follow any of these procedures in Tanzania. They were in cabinets that were potentially fireproof, but the room that they were in had patients coming in and out all the time, so it definitely wasn't a secure place for these confidential documents. The research personnel who worked on this clinical trial did this in their extra time. So, some of them were doctors, some of them were nurses, some were social workers, but they did this absolutely on top of everything else they had to do. And then study sponsorship. So what I learned from Dr. Ngoma, the Tanzanian PI, was that so INCTR was the overarching sponsor of the study, and they, sponsored it with drugs, with funds and everything, and that to them translated to 100% control. And so when I tried to get some information from INCTR, the code book for their database, they were really unwilling to help me, and that surprised me because as the Tanzanian PI, you would think that Dr. Ngoma has the study information, or has access to it, or they are willing to share it with him, but that did not seem to be the case. So, an interesting finding. And then finally, future career goals. Like I said, I worked in pharma before coming back to school, and so kind of with that background and with what I've done this summer and generally with my MPH, I'm thinking that I want to help just evaluate health interventions, whether it be programs or drug interventions, just make sure that they're ethically and culturally appropriate, because I think that's really important. And I think that without being on the ground, you don't see that and you don't know that, but I think that those are really the keys to making things helpful and effective. So thank you for your time.
Thank you, Stacey. Questions, comments?
One of the things you said about the medical records and the problem with organizing paper records and so forth reminds me that a physician once told me when I was going through similar problems with tracking records, he said, well, most of these patients are dead. This is ancient history. I don't even know why we're keeping them. And from the point of view of an epidemiologist, I'm thinking, well, how are you going to learn anything? tumor boards in our country were a new invention in 1960, and using those records to learn which treatments were more successful than others, side effects, and all of that comes after the study of the medical records after the patient's been treated. But a clinical physician finds the records most useful during the week of treatment. How many doses of radiation has this patient had? What sort of chemotherapy was my colleague giving in the next department? And all of that information is critical. And the other question, the question I have about Burkitt's is, why twice as many boys?
I don't know.
Any speculation in the literature about that?
I didn't see anything specifically. I read a lot of literature and I didn't see anything about that.
Other questions, comments? I think you mentioned very interesting point, Stacey, about data ownership and how the local Tanzanians did not have ownership of their previous clinical trial, which is really interesting. But it's something that all of you should be aware of for these international projects. The local collaborators must have ownership of the data. Data set is their patients and their information, and you can't just sponsor a project and say, sorry, you don't have any access to the data, which is really interesting.
She mentioned EORTC. Do you know what that means?
She mentioned INCTR.
INCTR.
International Network for Cancer Treatment and Research. And the interesting part here is that INCTR now is looking for money. So basically, they didn't say no to you. They said, pay us to have access to the data.
They're located in Lyon, France. A very large number of countries contribute to their budget, and they do international cancer research. It's a prime place in Europe to do research. And lots of Americans, particularly early career Americans, work there. So if you like to go to France, you like great food, Lyon is the place to be.
Thank you, Stacey. Okay.